Good morning, everyone. Happy Friday. This is episode 9 of When Is It About the Patient? This week, we're going to talk about OBGYN with Dr. Confer. And we'll get started with our first question. Dr. Confer, what is what's an appropriate age that a girl should first see a gynecologist?
Well, I mean, if you're talking for a pap smear, 21 now, and it doesn't matter whether you're sexually active or not sexually active, 21, because they found that the body will heal things when you're younger, no matter what, on its own. And people were getting too many procedures done. Cervixes were getting operated on when they didn't need to be. So they found that even if someone had a abnormal cells that were even fairly severe, they healed on their own. And so it wasn't worth doing the pap smear before that. So for a pap smear, 21. But for any other reason, we'll see anyone at any age. I mean, most kids are starting with their pediatrician, but say they have really heavy periods or they're sexually active and they're worried about birth control or a sexually transmitted infection. And, we'll see that, a lot of times that's a referral over from their pediatrician or their family practice doc, but they can be seen for that at any age. We'll do, birth control, or if the pediatrician sees something that doesn't look quite right and it's not sure what it is, they might refer, a young person to us, but, we would see them at any age for a problem visit, or like pregnancy. Obviously, people get pregnant before 21. And so, we see them at any age for that.
So even if they're sexually active and they're younger, they don't get a pap smear?
No. So say you're pregnant, you come in, you're pregnant, you're 16. We will do cultures. Those are state mandate. We do all the state mandated stuff, and we will do cultures for sexually transmitted infections, but we do not do a pap smear on anyone before the age of 21 anymore. Right.
Okay.
And that is a change. I mean, we used to do it at 18 or if sexually active, but that's not the case anymore. Like I said, too many cervixes were getting operated on unnecessarily that things would have healed on their own. And then, that can cause problems with pregnancy later on. So, yeah.
How recent is that change?
Oh, it's been a while. I mean, the PAP has really evolved in, like, say, the last 5 years. I mean, it's almost mind-boggling what the real rules are for who gets a PAP and who doesn't get a PAP. I mean, we follow all these. There's a whole bunch of pathways because now all PAP smears we can do HPV testing on. So high risk HPV is now tested. And of course, we'll talk about it later, but we're trying to vaccinate young people to wipe some of that out. But, 60% of the population carries an HPV virus. Not all are cancer causing, but because of that, we test for that. So depending on if someone's had HPV testing, what their age is, what their risk factors are, PAP smears have really evolved, and we're not doing them yearly anymore because the testing is better, and we don't need to do that every year. So it probably in the last 5 years, a lot of that has changed, but we haven't been doing PAPs before 21 for years. Yeah. I mean, shouldn't be doing PAPs before 21 for years, right?
Since we're on that topic, are you an advocate for Gardasil, the vaccination that came out? I think it came out, I don't know, maybe 10 years ago. I want to say it came out like when my kids were in
Yeah, like
teen.
my daughter's 27 and she got it at age 11. So that was 16 years ago, and it had been out. I know one of my partners actually had to pay cash for her son to get it, because when it first came out, they only approved it for girls, which
I
of
do
course
remember
is
that.
which is of course ridiculous. You can't wipe it out in the population with only vaccinating half the population, because obviously it's spread from one to the other. So again, her son is a little bit older than my daughter, and she actually had to pay for his vaccine because they wouldn't pay for it at that, insurance wouldn't pay for it. So it's probably been out more than 15 years, and there are newer and better ones now. I mean, the main one out now is Gardasil 9. So it actually vaccinates against 9 of the HPV. There's hundreds of HPV viruses. So the ones that we're vaccinating against are the ones that cause cancer, which the two that are the worst are 16 and 18. And those are the ones that are most likely to cause head and neck, vaginal, cervical, anal, all those cancers. But then Gardasil 9 also helps to prevent against 6 and 11, which we don't test for, like say in a pap smear, because they just cause warts, which aren't cancerous, but still can be very distressful for people to get, especially if they get it in the, vaginal area. So it does protect against that too. And so, yes, it's recommended starting at age 9. Gynecology offices don't really carry vaccines anymore, except for pregnant women. So pediatricians will still offer that. And probably most of them are starting somewhere between 9 and 11 and offering it. If you're between 15 and 45, it's a 3-part series. Between 9 and 14, it can be either a 2 or 3-part series. If you go to the pharmacy, which is where most people are going to get it, especially if they're probably over 15, you do not need a doctor's prescription unless you're under the age of 10.
Oh, okay. And for dummies like me, what is HPV and how do people get it? I know it has some sexually transmitted things, right?
Well,
So-
yeah, it's unfortunate because, again, most vaccines that we give children are given right when they're born. So, you give your kids hepatitis B right when they're born. Well, how do you think you're going to get hepatitis B? I mean, a healthcare worker obviously could get it from a patient, but, that's blood transmitted if someone's, sexually active, as in prostitution or IV drug use, but no one thinks that that's why. We're just trying to wipe it out in everybody. So no one thinks that's why their kid's getting it. We're just trying to wipe out hepatitis B for everyone. Unfortunately, because we give the HPV, which stands for human papilloma virus, which again causes head and neck cancer. It's not just for women and cervical cancer. It can cause anal cancers. It can cause anything that has squamous cells, which is the skin, which is the whole mouth, throat, all that. HPV can be connected to that. And so it certainly can be sexually transmitted, but it gets well, why my daughter's not going to be sexually active with multiple people, so I'm not getting that vaccine. Well, we're not saying that she is, but one partner, you can get it because so many people carry it. And again, since we're giving it in that age group where parents are starting to think, oh, my kid's going to start dating, that 11 to 15, they get very defensive about giving it. And you're just trying to wipe out another virus in this world. You're not trying to say that your kid's going to do anything more. And like I said, parents never think twice about giving the hepatitis B vaccine. And I try to, when I am explaining it in the office, use that analogy. You gave that when they were a baby and you didn't think your kid was going to be an IV drug user. So, we're just trying to wipe out a virus. We're not trying to say that your kid's going to do anything different than what you think they're going to do. Right.
That's interesting.
Yeah.
What are things, if we shift gears a little bit, what are things like if someone's wants to get pregnant and they come to see you, what are some of the things they can do to prepare their body for pregnancy?
Well, one of the things that you'd like to do prior to even trying is, check your family history. There's some things that your doctor could test for, and those things are usually they're recessive genes, meaning if you're just a carrier, you don't know you're a carrier. So if you could ask, family history, obviously, and then that could direct your doctor into what to draw. And then again, certain populations of people are at higher risk for certain recessive disorders, cystic fibrosis, sickle cell anemia, some of the thalassemias, Tay-Sachs disease. So those are all recessive disorders that unless you carry both genes, so if 2 parents carry a recessive gene, which in some, like in the Caucasian population, it's 1 in 20 of us carry cystic fibrosis. So if 2 people that are 1 in 20s carry that, there's a 25% chance that your child could have cystic fibrosis, which is, a long-term devastating disease. So, your doctor checking some of those things, again, getting family history and then asking, what am I at risk for? That needs to be tested prior to, if you want to do anything about it. Like we can't change once you're pregnant. But some of the things that you can do, prenatal vitamins with folic acid, taking it at least 6 months before you're trying helps decrease any of the neural tube type defects like spina bifidas. open defects, and the spine closes so quickly that by the time you're 6 weeks pregnant, it's almost too late. Like, the spine is one of the things that really develops very quickly. And so, starting that prior to, a lot of people, especially because it's young people getting pregnant. And if you're, not diabetic yet, but maybe would be if there's type 2 diabetes in the family, you may have insulin resistance. So put you at higher risk for gestational diabetes. So getting, weight, good diet and exercise under control before you get pregnant helps us during the pregnancy, right?
So when you talk about testing for different gene things, are you referencing like genetic testing?
Right. Yes. Yeah. Like I said, I'm not a big advocate of looking for everything and then being nervous about 1,000 things, but, very basic things that are very common, like, again, checking for cystic fibrosis or sickle cell or Tay-Sachs in, the Jewish population. Those things are fairly common, easy to test for, not super expensive. So yeah, those are some things, especially if you've asked and see if there's anyone in the family. But even if you don't have a family history, like I said, when there's a 1 in 20 chance, and that does line up that, you'd like to not have, cystic fibrosis, and that can be, you can then test eggs. I mean, that's up to you what you want to do, but you could test to see if you have an embryo with cystic fibrosis prior to
Are there
implantation.
any medications that you recommend the patient stop before getting pregnant?
There are most of those, again, it's not a huge amount. Sometimes we just need to tweak it, like some of the blood pressure medicines, the ACE inhibitor group, not good in pregnancy. Normally we stop those not so much before they're pregnant, unless, again, if they came in before and I saw someone was on an ACE inhibitor, I might stop that, but you don't know how long it's going to take someone to get pregnant. If their doctor felt that was the best medicine for them to be on, I probably wouldn't stop it until they came in. I mean, at 6 weeks pregnant, that's early enough. Those are the kind of things that you can stop. Now, there's certainly things that you can't take. I mean, like say someone's on methotrexate for, rheumatoid arthritis. I mean, there are obviously things that you absolutely can't take during pregnancy. So, most people, their doctors, when they start them, people doing the acne, the retin-A, those type of stuff, they've signed things that say, I know I can't get pregnant. They make them take 2 forms of birth control to be on it. And, I need to check with my, doctor prior to trying, how long do I need to be off of this? Most things clear very quickly. Like you stop it and within a month you can try for pregnancy. But so there's a very small amount, but usually if you're on those medicines that have to be stopped before pregnancy, your doctor's told you, like, you need to be on birth control and don't get pregnant while you're on this. But like I said, some blood pressure medicines, cholesterol medicines, there's very few psych and seizure medicines that you can't take, but some of them are at a little higher risk that we might tweak it and change it a little bit once you're pregnant. But most of those I would change in the first trimester when you came in. Like I'd have a quick visit with you at 6 weeks and say, you're on an ACE inhibitor. We don't like that. It can affect the baby's kidneys. We're gonna change you to a beta blocker or a calcium channel blocker. It'd be better. And then, go from there.
What are some common causes of infertility?
There are a lot of causes of infertility. Endometriosis, which is tubes can get blocked if someone has severe endometriosis. And even when tubes aren't blocked from endometriosis for some reason, and we don't know what that cause is, and just having endometriosis can cause difficulties getting pregnant. There are some chromosomal issues that can cause like a balanced translocation. So the person that has the balanced translocation means they have all the correct chromosomes, just one might be stuck to another. But when they pass that down, it's not passed on correctly because one's stuck to another. And so they get multiple miscarriages. Age can cause infertility, smoking. There are benign, smooth overgrowths in the uterus called fibroids. And depending on where their location is, especially if they're inside the uterus, they can cause problems getting pregnant with implantation, as well as other uterine malformations like a septum coming down the middle. Some people have a heart-shaped or a bicornuate uterus. those can sometimes be more difficult for implantation. Probably one of the most common in the United States is called polycystic ovaries, or not ovulating every month. And then people have difficulty getting pregnant. And that, that's one of the things that we check for early, because we can check with blood work to see if people have that. Some infertility, just point blank, it's unexplained. Probably two people have very minor issues, but together they cause a big issue. And then, whether through death or divorce, they get with someone else and they get pregnant. And we've never been, just couldn't explain why they got pregnant. Tubal factors, the tubes are blocked either just from birth because something happened, a prior surgery, someone had a ruptured appendix, someone had a bowel issue, whether it's scar tissue or infection that block the tubes. And then, of course, sexually transmitted diseases like chlamydia and gonorrhea, untreated, can go up and block tubes. And then the male factor, a low sperm count.
Is that the only thing for a male that could be causing infertility?
Well, again, that's not really my specialty, but I'm sure that, it's not just low count. They check other things with the sperm count. It can be the look of the sperm or the morphology. They check to make sure not only do the sperm, or is there a normal count? Do they look normal? How do they swim? They do the motility and they grade that. So, so it could be like slow swimmers that don't, look normal, plus the count, right?
And then there's things that you can do for most of those diagnoses, or?
Yeah. Like the first step, like I said, someone comes in, they've been trying, we usually say, especially someone say under the age of 35, we'd like you to have tried for a year, meaning you don't have to be, every single cycle doing ovulation, although now that's so easy and they get them, off Amazon and do pregnancy strips or on their phone. So a lot of people do that right off the bat, but, we can check, labs easily. And like I said, for polycystic ovaries, we would check your thyroid, prolactin, which is a hormone that comes out of the pituitary, and your insulin level, because those are all easy things to fix, which do affect getting pregnant. A sperm count, a semen analysis is an easy thing to check. And then if someone's had a history of multiple sexually transmitted infections or big surgeries, or, to the uterus or other parts of the abdomen, we can do what's called a hysterosalpingogram, or HSG, and just blow dye through the tubes to make sure the tubes are open. So those are some easy things to check to see, can we figure out what it is? And then, some things are easier to fix than others. Like someone that has a balanced translocation, you can't fix that. It's all or none. If the baby gets the chromosome that's stuck, you're going to have a miscarriage. If it gets the right chromosome, you're going to do just fine. Age, you can't change. If you're over the age of, 35, every year it gets a little bit tougher, and you start to get to mid 40s, and, obviously miscarriage rates go up because chromosomal abnormalities go up, and it gets tougher to get pregnant. Not everybody can get pregnant in their mid 40s. So, but PCO you can fix. Male factors, a lot of times, they can fix that. Tubal factors, if your tubes are blocked, yeah, you're a candidate for in vitro fertilization, but those are expensive and sometimes rate limiting factors for some couples. Obviously, smoking you can fix. Diet and exercise, help again with the PCO, with insulin resistance, and so yeah. And sometimes we do surgery. Sometimes fibroids or septums can be removed, and then that helps. So some things can be fixed. Other things, again, we have to do fertility treatment, which unfortunately in this country is not well covered by insurance, and can be a rate limiting factor for a lot of couples.
I hear you.
Yeah. What are your thoughts on the pelvic floor therapy? That seems to be newer. Maybe it's not, but it just seems to be newer. And
yeah, no, I think it is. I think it is new. I think it is newer, but I think they've gotten better. Well, first of all, more places have it better. They're doing more things with it. They have a lot of biofeedback, electrical stimulation. So people, when you ask someone just to do exercises, and obviously we've done that for 100 years. Hey, are you doing your Kegels? And people are like, yeah. And the doctor doesn't even sit down and explain how to do the Kegel, just says, are you doing your Kegels? Well, right. Are you really? Yeah. So, it's first of all, explaining it well so that people, so that's an easy thing to do, explain to someone how you can strengthen just at home. But, a lot of places, we have a couple of urogynecology offices here in town that have people that, are doing the biofeedback. So people actually feel that they're getting, but, again, yeah, I think it really does help support, especially if you're having, urine loss or some prolapse. It really helps pull that up. And if you're, diligent on doing it, it really does help.
Is it a good idea after pregnancy to get that kind of therapy or?
Yeah. Yeah. Because pregnancy, of course, you've stretched that uterus out to as far as it can go. And as it shrinks down, a lot of people get, now maybe just short term, again, prolapse that, they can, from that whole stretching and shrinking down, prolapse and incontinence. Again, you put a lot of strain on the bladder and on the rectum. So both urinary and fecal incontinence. So, women come in and they're distraught. They're, 2 weeks postpartum and, they've got enough on their mind, not sleeping and with a newborn baby. And all of a sudden, they're leaking urine or, having, trouble holding bowel movements. And so again, yeah, pelvic floor therapy does help. And like I said, some people can just do Kegels, like, just strengthening, doing sets of, I always tell people, the best way to start is when you're on the toilet, try to stop your stream and hold it for about 5 seconds. Then, you're at least contracting the right muscles. You don't always have to do it there, but at least understand which muscles. And then, while you're watching TV on a commercial, if you hold it for about 5 to 10 seconds, do sets of 10, 3 or 4 times a day, you'll strengthen that pelvic floor on your own. But if then that's not enough, like I said, there's quite a few places now. A lot of the physical therapy places do have the pelvic floor therapy, and with the biofeedback and the electrical stimulation, people can focus in better, and it really does help. Post-pregnancy, post-surgery, after hysterectomy to help strengthen those muscles. A lot of, and just as people get older, things fall after, especially people that have had multiple children. Yeah. There's a lot of reasons it does help. Yeah.
I'm going to just go off topic here for a second. So with that being said, if you don't keep all those muscles somewhat strong and engaged, you end up with problems that lead to, Kim, help me out, rectocele, is that, or like your uterus falling out?
Right. Yeah. Yeah. Cystocele, rectocele. Yeah. Some of that is genetic. Like you can't, strengthening the pelvic floor is not going to stop a cystocele or rectocele. Those are the bladder bulging into the vagina or the rectum bulging into the vagina. That's just muscles separating. So, yes, you can strengthen those muscles a little bit, but that's more genetics. You've got weaker tissue. And from, like I said, someone that straining for someone that lifts a lot of, stuff, a chronic cougher, multiple pregnancies. There's risk factors. Again, weight plays a big issue in that. If you have a lot of weight pushing down, that can cause more of that. The pelvic floor therapy helps lift that a little bit. And then, people that are having incontinence, a lot of times that's just the tube from the bladder out, the urethra drops down a little bit, and you can definitely pull that up with pelvic floor strengthening more than you can pull the whole bladder up, but you can pull that up. And that's really, by doing that, can really help with stress incontinence, which is, if the pelvic floor therapy is not helping stress incontinence, meaning when you cough, run, jump, sneeze, lose urine, other than putting something in the vagina, like a tampon to push that urethra up or something to push something up, it's really a surgical fix. So certainly strengthening those muscles is a good first try, right? There's no medication for stress incontinence, right?
Is it a surgical fix if you're for the rectocele?
Yes. Yeah, it's a surgical. Again, you can try to strengthen that a little bit, but if someone, the only time we fix a rectocele is if you're, again, very symptomatic, meaning having a lot of pressure, because as the bowel movement moves down, it bulges into the vagina, and then it's just right at the end, you can't get the bowel movement out. People have to put their fingers in the vagina to get the bowel movement out. That's when we would fix a Rectiseal. Otherwise, if it's asymptomatic, you wouldn't fix it. But
What if you're not a good surgery candidate?
well, for Rectiseal or Cystoseal, I'm not a good candidate. We can put pessaries in to try to, again, whether it's uterine prolapse, the uterus and cervix coming down, the bladder coming down, or the rectum coming up into the vagina, we can put pessary, which looks sort of like a diaphragm or we have all different shapes, but you put them in the vagina and try to hold things in. It's just, they're not easy to get in and out. And, if you're sexually active, that becomes a problem. I mean, obviously your gynecologist can get it out, but, at home, when we try to do ones that you can get in and out, but it's just not that easy. So, I mean, they're fixable for people who say they're a really bad surgical candidate, not sexually active, then they're great, but they have their limitations, right?
So if you have a pessary, that means you're going to have like this donut shaped thing in you. Does that just stay in there forever, or do you have to change it out? How does that work?
Well, like I said, some young people, if I have it in someone young, I mean, I'm putting one in that they can get in and out, again, because with intercourse, it's almost impossible to leave it in for intercourse. So yeah, they can get it out, wash it, put it back in. An older person, and depending on how severe the prolapse is, if I have to, they're all shaped like donuts, and some of them, the shapes are where, the suction power to keep everything in is so much that no way could someone get it out. I mean, they would have to come to the doctor. So they come, someone that's had it in for a long time might only come once a year for me to take it out, clean it, and put it back in, and make sure that we're not getting, erosion or tears in the vagina from it. But, other people, when they first start, might come in every, 3 months to 6 months to have it cleaned and make sure everything's going okay. Right.
All righty. Recently, oral contraceptives became over the counter. What are your thoughts on that?
There's only one over the counter. It's a progesterone only pill. And, we've had birth control pills over the counter for a while. That's what Plan B is, for emergency contraception, people can go to the pharmacy and get Plan B, which is just progesterone tablets that you take to try to prevent a pregnancy after, a condom breaking, or for whatever reason that, someone's using Plan B. But so they've approved a progesterone only. So progesterone only pills we use normally for people if you've got a blood clotting disorder, maybe a smoker over the age of 35, and postpartum, because it doesn't affect breast milk. Estrogen can decrease breast milk a little bit, so we use progesterone only pills. The only reason that we use combination oral contraceptives more, they have better cycle control. So when you're on a progesterone only pill, your periods aren't as regular. There could be a little bit more breakthrough bleeding, especially, again, if someone's on a higher BMI, higher weight, the combination oral contraceptives are a little bit higher as far as not getting the breakthrough bleeding and a little bit better contraception, right? But it's only progesterone only that's approved over the counter.
When I was young, the only option, well, there was the IUD, but the only option was the birth control pill. There's a lot of other options now, isn't there?
Yeah. I mean, we have the IUD, one with hormone, we have multiple with hormones, and then we have one without hormones. So, if someone cannot take hormones, we have the Paragard IUD. That's one of the longest standing ones. And it's actually, good for 10 years. You can take it out in a month, but you can leave it up to 10 years. And it's, a good form of birth control and has absolutely no hormones in it. The only problem with the Paragard is it can, for some people, make periods worse. And so if someone has bad periods to begin with, a little worse can be devastating. If someone's periods are fine, to make it a little crampier, a little heavier, not a big deal. But, a lot of people, when they think of getting the IUD, because the ones that are advertised, the newer ones, all have hormones in it, they're saying, wow, you might not have any periods at all, or very light periods, minimal cramping. So people are all looking for that when they're, they might say they don't want any hormones, but they also don't want to devastate, a really awful period. So, the Paragard's great, but it does not help with periods, whereas all the other ones are progesterone only, and they do make cycles better. But yeah, we have implants that go in the arm, good for 3 years, shot that's good for 3 months. There's vaginal rings that you only have to change once a month. There's patches that you change once a week. The pill, over the counter, not over the counter, but non-hormonal is Phexxi, which is gel that you put into the vagina 1 hour. You can't do it more than an hour. So obviously you have to be fairly diligent on this, but an hour before intercourse, and it's non-hormonal, but you do need a prescription for Phexxi, but it's one that's not hormonal. And then you can still get diaphragms. They're harder to get. I haven't fitted one. I think maybe one in the last 5 years. It's hard. No one uses them anymore, but diaphragms, condoms, spermicide.
Yeah, well, there's some gynecologists that won't prescribe them.
You can't find them. I mean, the last one I prescribed, like we literally had to go to, she went to a bunch of pharmacies, and I think eventually we had to order it offline. Like you just can't find them. Right. Yeah.
What's the most common gynecological surgery that you do?
Dilation and curettage, or we call it a DNC, and it's done for. It's the most common, but we do it for a lot of different things. So a DNC can be done for a miscarriage that someone doesn't pass on their own. It can be done to evaluate the lining for someone young that's just having really heavy periods, and we're looking to see if they have polyps, which are overgrowths of the lining. It can be in a perimenopausal or postmenopausal woman looking for overgrowth of cells that could lead to precancer or cancer. So we do DNCs for a lot of different reasons, but that's the most common gynecologic surgery.
How long should women get mammograms these days?
Now, we always used to do baseline mammograms between 35 and 40, and then start yearly to every other year, starting at age 40. Now, a lot of insurances won't pay for that baseline between 35 and 40. They just say, tissue, that people are too young, tissue is too dense, they're not seeing enough, maybe not worthwhile doing that baseline. So most people, unless you have a strong family history, like if you're a BRCA 1 or 2 carrier, a BRCA carrier, obviously that changes the picture, or a strong family, even if you don't carry the gene, if you've got a strong family history, mom got breast cancer premenopausal at age 37, we might start those mammograms earlier. But the ACOG, which is the OBGYN college, and the American Cancer Society recommend 40, and then every year to every other year until 74 at least. Medicare does pay for yearly mammograms, so they don't pay for yearly PAPs, which you don't need anymore anyways. And that's a tough subject because they'll pay for your exam at a family doc, but not at a gynecologist. So you do have to be careful if you're on Medicare where you're going, and understand that even though they'll pay for a PAP at this point every other year, which again, you don't even need them that often, they won't pay for that office visit unless you're seeing your primary care physician. So if you choose to see a gynecologist and you're on Medicare, you'll always get stuck with the office visit unless you have a good secondary insurance. But mammograms are paid for every year. And for breast cancer, unlike cervical cancer, we stop pap smears because cervical cancer goes down with age. When someone says your lifetime risk of breast cancer is 1 in 9, that's not at your age right now. That's at your life expectancy age. The risk is 1 in 9.
I can't believe that insurances won't cover before 40 with all of the people. I mean, and even you hear about people will say, oh, I can't think of his name. He played for Ohio State. His wife got breast cancer and actually died in her 30s. And there was just there's a girl on the news, I guess she's an actress, Olivia Munn. She's in her 30s, breast cancer. More and more people are being diagnosed with breast cancer now under 40.
Mammograms just aren't that sensitive before the age of 40. It's not that, in all fairness, that the radiologist can't read it well enough to diagnose a cancer from it. So they're saying, why do something that, now you're putting the doctor at risk because they're going to miss something that they can't see. I get that a little bit, again, I'm not saying that all insurances have stopped covering the 35 to 40, but it's a difficult read for the radiologist. Breasts are just, the dense tissue makes it a very difficult read. And so they're saying until there's more fatty replacement, until people get over the age of 40, and again, they start adding adjuncts on. When you get a mammogram, they assess your breast density even at, say, age 40, and say, if your breast density is over X percentage, and I forget what it is, 13 or 15%, then they'll call your breast dense and they'll recommend molecular breast imaging, which is a secondary feature, which most insurances do pay for after you meet your deductible, because it's no longer a screening. Like once you start going mammogram, pap smear, that's all covered under screening, which for most insurances are covered. Once you hit a diagnosis, you've got to meet your deductible. So if you got a mammogram and that they paid for that, but that comes back dense breast, and they said, well, we'd like you to go get a molecular breast image, which again is an easy test. They give you a little injection of some radioactive material, and they just do each breast position, two on each side, for 10 minutes. You sit in each pose. They don't squeeze you. You just sit in each pose. And so it's a pretty easy test. It's better for dense breast, but then it does get tagged with that diagnosis. And if you have a big deductible, you'll be paying for that. And then if you have a family history, they add an MRI on, which they do that then at 6-month intervals. If you're a BRCA carrier or have a strong family history, it would be mammogram, 6 months later, MRI. And again, some insurances are better at covering that than others. Right?
So if you get diagnosed with dense breast and then you go have an MBI, then the next year when you want a mammogram, does that mean that it's going to have to be diagnostic, not screening?
No. You still go for your screening like each year, you still go for your screening mammogram. And then if that year, like, because breast density can change. So, I myself have had some years where that percentage was over 15% or whatever the percentage is. I can't remember exactly, but and then I got recommended for the MBI, and then the next year it wasn't. So I was obviously right on the cutoff. And so no, just the MBI, you get tagged with a diagnosis. You still do a screening mammogram. Even people with like high risk, you can still do a screening mammogram, and then the MRI 6 months later is going to get tagged with the high risk breast cancer. And again, you'd have to meet your deductible or however your insurance works. But yeah.
Okay.
You can always do a screening mammogram, and then the other will get tagged with the diagnosis.
And I ask that because, a lot of people opt for that Cologuard. And if let's say you get a false positive with Cologuard, that's going to make it so your colonoscopy is not going to be a screening colonoscopy. Because now you had a false positive from your Cologuard test, right?
Right. Yeah.
Okay.
It does, right. You're taking a little bit of a risk. You're saving yourself the risk of, obviously colonoscopy has, more risk than Cologuard. So, some people will say, I don't want to take anything surgical has got risk. So, but yeah, if you get, you have to be a low risk population to even qualify for the Cologuard. But if you are, there is a small false positive rate. And if you get tagged with that, then yeah, your colonoscopy could then hit not that it wouldn't be covered, but you could end up in your deductible and have to pay the deductible, right?
It's somewhat ironic because I do remember that a medical advisor from one of our local insurance companies 20 years ago said, no carrier wants everybody to get a colonoscopy. They're never going to recommend that everyone get a colonoscopy. And I guess somewhere along the line, they figured out that screening and prevention was better than like waiting till they had cancer.
Well, it is, but Medicare is notoriously bad about covering. Most private insurances have gone where anything screening is covered, and then anything that's not screening that you have to make your deductible. But Medicare, a lot of screening features are not covered. In Medicare, some screening stuff is not covered, so they're notoriously bad for that.
Is that traditional Medicare, do you know, or you don't know the difference?
Yeah, right. Yeah. I would think more traditional Medicare, because a lot of times when you're hooking it on to a provider, then they do cover the preventative stuff, right?
Okay.
As women get older and they face incontinence and vaginal dryness, we kind of talked about incontinence already, but are there preventative steps to help avoid, or is physician intervention needed?
No, again, with incontinence, weight, is a big issue for, helping. So diet, exercise, watching your weight, the pelvic floor, support, which we already talked about, really helps with the incontinence issues. Now, vaginal dryness, that comes with menopause. And so, that's a little bit tougher. Some people, get it right away when they hit menopause. Some people not till 10 years into, menopause. So, it just depends. Obviously there's over the counter ways we can treat that, but, vaginal dryness can be uncomfortable just in itself. It can cause urinary tract issues. People get more as the vagina dries out. So does the bladder is right there too. It's not just, it's urogenital. So it's the bladder and the vagina that are drying out. So urinary tract infections go up, nighttime, having to get up 5 times at night, having to go more often, even during the day. So, estrogen affects all of that. And of course, intercourse can get painful. I mean, it can be just painful just in itself because of the dryness, you get cracking. So, I mean, there's over the counter and prescription medications that we can, use for that.
So we talked about some hormone replacement drugs after hysterectomy, the estrogen. I recall when I was working in OBGYN, women asking for, was it called bioidenticals?
Yeah, bioidentical. We've got a couple nice pharmacies here in town that will make up the bioidenticals. That's where the pharmacist is actually, we draw, as the physician, we'll draw the labs, meaning check a bunch of hormone levels, send it over to the pharmacist, and then he sits down with the patient, discusses what their symptoms are, looks at their lab values, and then decides exactly what to put in the combination. Is that better than what the pharmaceutical companies are putting out? I don't know. The big studies are all going to be done by pharmaceutical companies because they're expensive. You're not, bioidenticals aren't going to have, they aren't going to do the studies. So I said, we got to treat them as though they're the same. You got to extrapolate and say they're the same thing. So risks and benefits, but some people feel that, tailoring it more to themselves might help more than getting what everybody else is taking. Yeah, I have people that take the bioidentical and love it. Insurances are paying better. At first, you were paying that all out of pocket. So, the pill or the patch or the cream that I got from the pharmaceutical company was covered, and you went to the pharmacy and got the bioidenticals and you're paying $100 a month. That limited how many people could do that. But now insurance companies are paying for that more often. So yeah, I think they, for the same symptoms, hot flashes, night sweats, not sleeping, irritability, moodiness, vaginal dryness, painful intercourse, and then the bladder issues. Those are all issues why people take hormone replacement. And depending on whether you have a uterus or don't have a uterus, then you need to protect the uterus if you have one. So then you have to take estrogen and something, whether it's progesterone or something, to protect the uterus. If you don't have a uterus, you only have to take estrogen. And then, if you're having systemic symptoms, meaning the hot flashes, the night sweats, the not sleeping, the moodiness, you have to take more than if you're just having the bladder and vaginal symptoms. That is less risk and works solely on that area. So if those are the only symptoms you're having, we use medications that I would say are safer. They don't affect systemically. So, if you're only having to use a medicine that affects that, it's less risky, and there's no reason to take something that affects the whole body when you only need a small portion of your body taken care of.
So women that have hysterectomies, and I know they have them at all different ages, what are the physical risk factors after a hysterectomy?
Well, again, that, depends on age. Someone that has a hysterectomy premenopausally is going to have more risk than someone that has it postmenopausal, meaning once your periods stop and you're ovaries have shut down, those organs aren't working. So, I mean, there's obviously everybody has equal risks as far as the surgical risks, but afterwards, if you're taking out an organ that's not working, there's less risk to it than someone that, say, is having it done at 25 or 35 or 45, that their ovaries are still working. Ovaries have a lot of protective effects. Number one, women have heart attacks or heart disease later in life than men do because estrogen is protective on the cardiovascular system. So, most women don't have heart disease until after menopause, whereas men start earlier. So, to protect the heart, bones are dependent on estrogen. Estrogen helps put calcium into the bones. So, protects the bones, it protects the vagina, it protects the bladder, it protects your skin. So again, it has a lot of protective effects. So if you're premenopausal, we would recommend being on estrogen. Postmenopausal women, after your ovaries have shut off, the only reason we would do hormones is if you were symptomatic, meaning having problems with the bladder and the vagina, or if you were having the hot flashes, night sweats, trouble sleeping, and the mood changes, then we would start hormones. Right?
And how long would you recommend they take hormones?
Yeah.
Oh, yeah. Well, someone that's premenopausal, again, we probably recommend until around the age of 50, just for protection wise, for all the things that I named. And then after that, again, you could try weaning off and see if you actually have the menopausal symptoms. As long as someone's symptomatic, quality of life means a lot. And so, if someone's having 10 hot flashes a day and they're, can't concentrate at work, can't enjoy the day, it's not worth coming off the medicine. If they're not sleeping all night, when you don't sleep, you're miserable the next day. If someone is having so much pain in the vagina that they can't concentrate, they can't have intercourse, they're having to get up 5 times at night to go to the bathroom, it's obviously worth staying on it. So I don't really have a time frame. Again, for someone that's before menopause, I say stay on it till age 50. And then if you're doing great, we can try weaning off and seeing if you're symptomatic. If you're not, it's fine to be off of it. If you're postmenopausal and we do it, you're symptomatic, we start it and we keep it going until, say you have a hysterectomy at 55 and you were on medicine because you were having hot flashes. And then at 58, you say, boy, I haven't had a hot flash in 3 years. Now you're on medicine. But I say, okay, well, try weaning off of it. Try going to every other day and seeing how you're feeling. If you feel great, we'll go to every third day for a couple weeks. If you're still feeling great, we'll go to once a week and then you might get off of it. If you feel great at twice a week, but not at once a week, you stay at twice a week. It's less medicine. So it just, it's dependent on symptoms.
Gotcha. Carrie, you have any other questions?
No, just, is there anything else that you would like people to know that we haven't covered so far? And I feel like we've barely touched all that happens in your world. So,
Yeah. Let's see. Well, as far as incontinence, we sort of talked about stress incontinence, meaning the kind that you get when you run, jump, cough, sneeze, but there is also urge incontinence, which there are a lot of medications out there to help with that. And urge incontinence is, I got to go when I got to go. Like people just get hit. And as you get older and you don't have estrogen, again, your bladder is more sensitive. It contracts more and people have that. So that isn't a surgical fix. There are medications out there, Botox, biofeedback. The medicines are anticholinergics. They can give you a little bit of dry mouth, but it does calm the bladder down. So not all incontinence is surgical or having to put a pessary in. There are 2 different types. So we do have very good medications that help with, and bladder training that help with urge incontinence. And of course, like I said, alcohol, caffeine, smoking, and weight loss all help with both things. And then the vaginal dryness, there are some over-the-counter medications that are easy for people to get. So you don't always have to go right to hormones and a prescription for that. One of the ones that I've prescribed for years is Replens. And so again, my breast cancer patients that can't use hormones or, would really prefer to stay away from hormones, Replens is a vaginal moisturizer. So it's not a lubricant. Anyone can use, a lubricant for intercourse or, to help on short term, but something that you use say twice a week, like you would a vaginal estrogen, and it's gone in head-to-head studies and done just about as well. Replens is one that you can use twice a week, say Monday, Thursday, Tuesday, Friday, and has no hormones in it, but not only helps with vaginal dryness, but also helps, people always think I'm dry, and so if I just use a lubricant during intercourse, I'm going to feel better. Well, you're not. I mean, you might not, but if your vagina is not expanding, you almost have the same amount of pain, and then you get the burning and the micro tears in the vagina. So you really need to get that tissue into better shape. And so using a vaginal moisturizer like Replens, Uberlube is another one you can get over the counter or off the internet, helps get the vagina into better shape so that people aren't having pain with intercourse, and it's non-hormonal. So it's a place to start. Like, I don't always write a prescription immediately if people are just having vaginal dryness, vaginal burning, even with going to the bathroom frequently at night or having pain with intercourse. You can start with some over-the-counter medications, and they, for a large amount of people, those will help in themselves. And like I said, there have been studies that have shown that Replens does quite well, even not maybe quite as good as a vaginal estrogen, but well. And then, hormone replacement, I said, we have ones that just treat the vagina, and we have obviously the bioidenticals that we can have made. You need a prescription for those, the ones from the pharmacy, but there are alternative groups of medications for anyone that, there are certain groups of people that can never take hormones, people that have really high risk of blood clotting disorders, cancer patients. So there are medications that treat hot flashes, night sweats, trouble sleeping, the moodiness and irritability with no hormones. I mean, these are prescription, but there's one that's a blocker of endokinin B in the hypothalamus. That's a new one out, Bizo, and that helps with hot flashes. And then we've used the SSRIs off label for years. There's one now that is FDA approved called Brisdel. It's just the same as Paxil or paroxetine. It's just labeled from the FDA for specifically hot flashes, but we've used Prozac, we've used Paxil, and those are all SSRIs that help with hot flashes. And then Effexor is in a different category. It's still at higher doses, an antidepressant, anti-anxiety. It's not in the SSRI category. It's phenyloxifin, and it's off label also, but does help with trouble sleeping, hot flashes, night sweats. And those have no estrogen, progesterone in them. So people that can't take hormones, we do have prescription medications that you can use for menopausal symptoms, because like I said, some people's lives are really affected. Yeah.
Thank you.
Oh yeah, you're welcome.
Anything else, Carrie, that you can think of?
No, I think this has been excellent.
Yeah, it was really good. I didn't know you were that smart. I'll edit that out.
You don't have to edit that. I agree. But I like to talk, so.
Yeah.
Yeah.
No, this has been really good. So we want to thank you for joining us today. We really appreciate it.
It was fun.
Good information. See, it is kind of fun.
Yeah.
So thanks so much.
Yeah, have me back anytime.